Good morning, and welcome to this year's Ovarian Cancer Research Alliance National Conference, Uniting for Hope. I'm Beth Karlan. I'm a gynecologic oncologist out in California at UCLA. I'm the Nancy Marks Endowed Chair in Women's Health Research. I'm a professor and vice chair in the Department of Obstetrics and Gynecology, and I'm the director of cancer population genetics at our cancer center. I'm joined by my friends and colleagues, Dr. Andrew Berchuck, who's the James Ingram Distinguished Professor of Gynecologic Oncology and the Division Chief for Gynecologic Oncology at Duke University, where he directs the Duke Cancer Institute's Gynecologic Cancer Disease Group. And again, my other friend and colleague, Premal Thaker, who's the David and Lynn Much Endowed Chair in Gynecologic Oncology and a Professor of Obstetrics and Gynecology and Director of the Gynecologic Oncology Clinical Research at Washington University in St. Louis. So welcome to all of you. We're going to have a next Ask the Expert session, focusing on some of your many questions that were already submitted. I think it speaks to the engagement of all of you for taking control of your survivorship, and we're here to help you and to answer your questions. It's a very exciting time to be caring for women with ovarian cancer, because we have so many more tools in our armamentarium to allow you to live your best lives despite having ovarian cancer. In this session, we're going to focus on many of your questions that have to do with genetic testing, rare tumors, lifestyle screening. I like to think about genetic testing almost as precision prevention, that if we can do appropriate genetic testing and have aspects, we can actually prevent ovarian cancer. So why don't we get started with some of our discussions? I know we were chatting a bit earlier, and Dr. Berchuck's been really had decades-long interest in this, in doing germline genetic testing for patients with ovarian cancer. Dr. Berchuck, you want to lead us off with that?
Sure. I've been at Duke for 35 plus years now, and was around when BRCA1 and 2 were discovered, and before that, in the mid-90s. Early on when I got here, we were trying to do prophylactic surgeries and removing tubes and ovaries based on just family history. And I know you were part of that era too. And, subsequently after BRCA1 and 2 were discovered, we found mutations in those families, but had often done prophylactic risk-reducing surgeries in women who, it turned out, didn't have the mutation, even though it was in the family, because, each individual is only going to have a 50% risk if they have a parent with the mutation. So it was a major, major advance in the mid-90s to discover BRCA1 and 2, and at Duke and in California, all around the country and all around the world, folks started putting together hereditary breast ovarian cancer clinics and doing testing. Unfortunately, though, for many years, the testing was really very expensive, about $4,000. And so we really only confined it to the most florid sort of family histories riddled with breast and ovarian cancer. But fast forward now, 30 plus years later, and all the guidelines from NCCN and others say test every woman with ovarian cancer for these mutations, and not just BRCA1 and 2, but other related genes and the Lynch genes. And so it really provides us now with a tremendous opportunity to do good and to actually prevent some of these cancers that tend to present at a stage where they're not curable, treatable, but not curable.
Yeah, I think so. NCCN guidelines, which is the National Comprehensive Cancer Network, has recommended universal testing for all women with ovarian cancer, universal germline genetic testing at the time of diagnosis or any time in the course of your disease if you've not had it done, for really over a decade. We're still not delivering on that promise of, getting tested when you already have ovarian cancer can allow you to get better use with PARP inhibitors, can allow you to have more screening for breast cancer, because if you survive your ovarian cancer for many years, you don't want to get struck again by lightning and have to deal with a new cancer. And we really need to better think, how do we make sure that's accessible to everybody? Dr. Berchuck spoke about cost, but even now with more manageable costs at $200 or $300, we still don't get that out to all the patients. It is every woman with ovarian cancer. It's not just those with family histories. So we really do need to be doing a better job there. And then the other point I'd make when we started talking about precision prevention is the importance to all of you. If you do find out that you've had testing, you find out you have one of these pathogenic variants or something they think might have led to a hereditary predisposition, tell your family members. Thanksgiving's coming up, male members and female members, the BRCA genes, both BRCA1 and BRCA2, they're not sex linked, even though so much of the work was done in breast and ovarian cancer patients, pancreas cancer, prostate cancer, melanomas, other cancers that are not just in women, also at an increased risk. So please have your family members have what we call cascade testing. Often that can be done very efficiently just by saliva samples. So maybe not after dinner on Thanksgiving, but you can have other family members and you can play a role in keeping them healthy. Premal, there were a lot of questions though about if I have a family history and I don't have any of these genetic alterations, what can I do to not get ovarian cancer? Are there any more generalizable preventative interventions that we can recommend to women these days?
Yeah, so I think, what we've also learned is when we call it ovarian cancer, we do think that most of these arise from the fallopian tube itself. And so that's been like groundbreaking work that's been done by a lot of our pathology colleagues in conjunction with GYN oncologists. So doing a salpingectomy, like removal of the tubes, has been very beneficial for seeing a reduction. And a lot of women, as we know, use that as a method of contraception. So instead of just getting it ligated where they take a piece of the tube, actually asking your provider to remove the entirety of the fallopian tube. So I think, one of the messages I know a couple of years ago at SGO we were trying to say, which is our national meeting, is, women who decide to combine, especially with the general surgeon, get their gallbladder out and they're going to get their tubes out, maybe to combine some of these too. So women don't have to keep going under the knife for procedures too.
Opportunistic salpingectomy, as it's called, taking the opportunity to remove the full tube, is actually endorsed by the American College of OB/GYN, Society of Gynecologic Oncologists. So I think if you have the genetic testing because of a family member and you want to reduce your risk of ovarian cancer, really having the fallopian tubes removed, whether or not you have the genetic alteration or not, it's being recommended. It also provides you, I see a lot of the students even here at UCLA who are young, and, you talk about when should you have the tubes removed. As you say, it does provide a means of contraception, so to speak, but it also is a discussion about ways to do pre-implantation genetic testing. There are some patients who, because of their very strong penetrance in their family of the various cancers, want to use assisted reproductive technologies to make sure that their subsequent children don't have one of those same genes. Right. And that can still be done. So removing the fallopian tubes doesn't change your time of menopause. You still can get pregnant and still carry a full pregnancy, although you do need to take care of assisted reproductive technologies. But it's probably the most effective thing we can do and recommend to prevent ovarian cancer. The Ovarian Cancer Research Alliance had a very important announcement, partnering with many of the pathologists and other GYN oncologists to really make this, to try to increase knowledge of this recommendation. Do you want to start and perhaps talk about some of our, I'll say, our disappointment in our ability for early detection of ovarian cancer at the current time?
So, there definitely have been large population trials that have been done in the United Kingdom, as well as we had one here in the United States, trying to see if we could detect ovarian cancer earlier by doing serial ultrasounds along with our blood test of the CA-125, which every ovarian cancer patient knows what that blood test is, to see if we could find, is there sort of algorithms or sort of ways to detect these sort of cancers earlier, because as we know, as Dr. Berchuck eloquently said, stage 1 and 2, we definitely cure, even though we have lots of treatments now. We obviously would like to find no patient with cancer, but if we can find them earlier, we have a much better chance. And so these trials were done. And unfortunately, we found in a general population, we would have to almost do anywhere from 1,400 or 1,500 surgeries to find a cancer. And we weren't necessarily always finding them early either. A lot of them were still a stage 3 and they were being serially monitored. So it just lets us know that our detection with radiographic imaging along with CA-125 is still not the best measure. And I think there's lots of trials or discovery trying to look, is there different changes we can figure out from the fallopian tube and sampling from, secretions that might help us detect these cancers earlier, but those are still, I think, all in the preclinical or early arena.
Yeah, I think early detection is still the holy grail for us, but we also don't want to mislead patients with false hope or false reliance that the screening really works. In fact, the current NCCN guidelines, just as they recommend universal genetic testing, they actually they no longer recommend annual or semi-annual ultrasound in CA-125 because of the concern that patients may, feel more assured because of that, and not do that. Now, while that may sound disappointing to many of you, it's because we realize we need to invest in something better. And there are many new modalities looking at other ways to look at circulating DNA, fragmentomes, methylation, there are so many companies, investigators, money, science, passions going into finding means of early detection. I'm an optimist, so I like to think we're getting a lot closer with all the science and all the technology. So stay tuned. Go ahead, Andy.
Yeah, so the United Kingdom trial, the UK CTOX trial, recently had an updated publication last month, and they are able to effect a stage shift with ultrasound and CA-125 screening, where more of the cases are detected at a somewhat earlier stage. But unfortunately, that didn't translate into a significant chance of surviving ovarian cancer.
Right.
So to me, there's a little bit of hope there that, yes, there was a stage shift. And the other thing that's important to remember is that in the UK CTOX study, they've created a biobank of samples from all these patients. So all the new sort of approaches that you just mentioned, it's like you don't have to go do this whole study over again, which took 20 years to do. You can dive into the biobank and sort of look at those samples and determine if, this new marker is better than CA-125 or a combination of markers. So I do think there's some hope there to use the UK CTOX biobank as that sort of a resource.
Yeah, there's UK CTOX. Actually, the Women's Health Initiative has a very rich biobank as well, the prostate, lung, colon, ovary. So I think there are a number of these things that our investigators from the past, many of us were involved in those studies, or at least I know I was really, making the investment in these biobanks for the future as technology has gone on. It's an incredible resource. And I do think we all believe the Holy Grail will be finding a way to have annual screening or early detection, and we're working towards that. I just want to delve in. I'm sorry, go ahead.
I have to say one other thing.
Yeah.
I think that's a great, mention for our population who's listening to us today, is that when we ask you to participate, to give blood or give a tumor, it's for exactly this, right? You may not see the benefit right this minute, but there's future developments all the time, and we're all optimistic. And without the power of the biology, we really can't make these discoveries. So I think, I always feel very grateful when a patient signs to say they'll biobank with us. But, just also, if you have that opportunity, please take advantage of it, because you can make a huge difference for the science.
Absolutely. And I think all of us as clinicians know that the tissue that's necessary for your diagnosis will come first. But often with ovarian cancer, there is extra remnant pathology specimen that can be invested in the future. But Premal, it's a perfect segue. When we talk about genetics, I think we were talking about genetic testing for germline inherited mutations. But maybe you can just talk a little bit about the difference between germline and somatic alterations in doing next generation sequencing and molecular profiling of the tumors? And how does that differ and how is it complementary?
Right. So, I think it's interesting. The key is everyone should get tested, as we've mentioned, but a lot of times you will get somatic testing, and that's a fancy way of saying we're looking in the actual tumor itself to see what molecular changes there are. So does it have a BRCA mutation? Does it have a BRIP1 or certain these other homologous recombination deficiency profiles or other profiles, because it could be also Lynch syndrome. We don't want to say genetics is only BRCA, because there are a percentage of patients who will have Lynch syndrome and will develop ovarian cancer. So these are just looking with next generation sequencing, which is a fancy way of looking into the tumor's DNA or molecular protein changes to see if there are these abnormalities. And then that can help your physician give you targeted treatments. But then on top of it, we also do our germline testing, which is really the DNA or genetics that are passed down from your family to you. So they're definitely different. And I know there are some places that we want everyone to get both, but sometimes they do get one or the other, as a screening, but that is not the recommendation. You should get all testing. So it is important because when we talk about cascade genetics, we want to make sure to inform your family, and that's based on your germline of what genes you got from your parents. But then there's the molecular, because we know that cancers unfortunately grow because of these abnormalities. So it's not in your genes, but it definitely affects your tumor microenvironment, potentially your treatments. So they're very important. And I think it's getting complicated, right? Because when we have these sheets of paper of molecular sort of, characterizations, I make sure to give it out to patients, because I do think sometimes things that are not targeted today might be targeted literally next year, right? Like as we're seeing with the HER2 story with Herceptin or, ADCs that we talked about before. So it's nice to know what your characteristics are.
Yeah. And I think, it's the somatic tumor testing, which is, again, each cancer has genetic alterations and many drivers that make it behave like a cancer and not stop growing and metastasize. Most ovarian cancers, probably 95+%, have a P53 mutation, and we don't really know how to target that one quite yet. But there are many others, CCNE1. I mean, there's many characteristics that will come out from these reports that will give your physicians an idea of what might be the best target for you. So it is different. It's based on the tumor, it can be on a biopsy, but it's different than inherited genetics. It's really what's driving your tumor forward and can be very, very useful. And then there's circulating tumor DNA that can be used for many ways. And do you want to talk about ctDNA for a moment, Dandy, or?
Well, I think it's premature. It's not something that's really been FDA approved, or we haven't really done the studies yet that would be needed to sort of demonstrate the clinical efficacy, in my opinion. But I think the idea there is twofold. Number one, similar to CA-125, I think most of the meeting would understand that when your CA-125 is high, when you're diagnosed, if it goes back down to normal, and that's usually meaning that the surgery and chemotherapy is working, the cancer is in remission, and conversely, when the CA-125 starts to go back up, that there's a recurrence. So, in theory, monitoring circulating tumor DNA could be an even more sensitive sort of approach to that sort of monitoring. But CA-125 is pretty darn good. I'm not sure there's a really great unmet need there. But then the other idea is that maybe circulating tumor DNA sampling over time is a way to sort of monitor changes that develop in the cancer that would predict, resistance to certain types of therapies. For example, in BRCA mutation carriers, it's been shown that the mutation in their tumor, whether germline or somatic, can be actually corrected, so-called back mutation, where you then have a normal BRCA gene. And so one might go from being potentially susceptible to PARP inhibitor therapy to resistant. But beyond that, we don't really have other examples yet. But it is a potentially interesting paradigm for the future if we had more drugs where we understood a mutational change that would sort of direct therapy. But I think it's at this point maybe a little premature.
In my practice, I think there's two places I've been using it, and they're really different types of analyses. One is, as Dr. Berchuck was referring to, sort of surveillance, where the tumor is looked at the time of surgery or the actual tumor, and a panel is made for your specific tumor that can then be used over time. Sometimes that can be helpful with immunotherapy, where you see pseudo tumor, where it's the imaging may not be exactly right. And those changes you can confirm or not often with these tumor panels of circulating tumor DNA. And they often will go up even before the CA-125. And again, that's been shown more in things like colon cancer, not yet in ovarian cancer, although there are some publications. And then there's the idea that circulating tumor DNA, the second piece that Dr. Berchuck was referring to, instead of a biopsy. So there can be these reversion mutations in BRCA, but there can be other changes, and the tumor may not be in an area where it's easy to do a CT guided or ultrasound guided biopsy, where you might be able to find those markers due to shed DNA, especially if there's a larger tumor burden with a recurrence. And that's a different type of analysis of circulating tumor DNA, but something that I think is hopefully being able to do liquid biopsies and save patients a few needles is the potential goal, and is something that you can discuss with your physician as another option. We were talking earlier about survivorship, and lifestyle. And everyone here at the conference is doing something right. Empowering yourself with information is really helpful. But what do you do when patients finish their primary treatment and their maintenance treatment? What kind of survivorship care plans or other recommendations do you make to your patients?
So I think, that's a great question. And I think it's one that we all struggle with a little bit, because it's hard to give precise, but I think it's almost looking at the American Cancer Society for Healthy Living, like good nutrition, getting exercise. I think there's definitely a role for a lot of patients for like mindfulness or journaling, or sort of, just psychological, I guess, almost like a breather in a sense, because some ways it's almost this yin yang, like now they're not seeing you to get treatment. So when they are a survivor, there's that scare of being away from you too. So trying to approach that sort of healthy balance of letting them regain their life, I think is so important, and empowering our patients. So that's what I sort of recommend, or, good sleep, things that almost sound like you're talking to a kid, right? Like do these good, healthy things that we know are beneficial, but I don't have otherwise like a magic. But I think the main thing is I'm always impressed with what my survivors are doing when they come back in 3 months. Like some are like, I trained for a marathon, or I like did this. So I feel like a lot of women do take this as a great opportunity to re-engage with life again and get back into their routines.
I agree, and there's some interesting data out there that we talk about in our research groups in relation to statins, aspirin, estrogen. There's some small trials that have suggested a reduction in recurrence with these sort of interventions, but really definitive studies haven't been done. It's hard to get those studies funded because, no drug company wants to lay out millions of dollars to do a study of whether aspirin helps, right? Because there's no profit in that. So I feel like in terms of secondary prevention and reduction of recurrence risk with these types of almost lifestyle-y kind of things, that there's been an underinvestment. And I hope that in the future that'll change and that we can do some of those sorts of studies.
Yeah, there are the American Cancer Society and others are looking at lifestyle interventions. I just whether it's placebo effect or not, I think empowering yourself, looking at diet, there's no one special diet. No one has to go become a vegan or, do intermittent fasting. But I do think that looking at what you're eating, limiting red meats, limiting alcohol, not smoking, having good sleep hygiene. Sleep is something, eating well, exercising, and sleep. They really all go together with equal importance. Anxiety, fear of recurrence. I think having a survivorship care plan, having a survivorship visit with either your doctor, a other care provider, to really relook at all these aspects in your life, to be intentional about them. It may be aspirin, it may be metformin, it may be, see what you and your care provider feel is best for you, in terms of your other perhaps comorbidities, lifestyle, and things like that. But try to move. We have good data, especially from breast cancer survivors, that physical activity can reduce risks of recurrence by up to 40%. We don't have those large numbers with ovary cancer yet, but clearly some type of physical activity, it can be walking, cycling, getting out, having community, having people around you, seeing your healthcare provider. I think all these are ways to, if you do have a recurrence, have it found earlier, and ways that you can, again, live your best life.
So I just want to add to that. I think a point that you made, Dr. Karlan, which is super important, is having a community. So, part of the research that I like to look at is looking at some of these factors. And one of the biggest ways that we found patients have sort of maintained, being longer term survivors is actually social support. And you don't realize, because sometimes you feel like you should get isolated or you narrow your support system. And that's probably the time you need your support system the biggest amount. So really engaging, because it does help you in all these aspects of anxiety and depression and making you move, because you're more motivated to move if you're moving with someone than sitting by yourself. So, I think even though we might say these things being like as common sense, it's implementing them, right, is the key thing. Finding the time, getting out there and moving and doing all of this.
So congratulations to all of you that are here, because you're part of a community. Yeah. And hopefully you will follow up with others you meet, who have walked your same shoes, and share those same concerns, fears, and celebrations of each anniversary that you all have. I want to switch gears a little bit and talk about some of the less common subtypes of ovarian cancer. Maybe we can start off with low-grade serous ovarian cancers. It's only about 10% of ovarian cancers, something we've known about for a long time, understudied, but recently I think there have been some exciting new approaches to those patients. Dr. Berchuck, do you want to start out with some of the exciting new approaches to low-grade serous ovarian cancer?
Sure. Again, at the beginning of our careers, we referred to low-grade serous cancer as grade 1 serous cancer, whereas the high grade was grade 3, poorly differentiated, and just assumed they were slightly different flavors of the same, disease. But we now know that the underlying mutations that cause the low grade versus the high grade are completely different. So as mentioned before, the high grade is almost always P53. The low grade tends to be KRAS, BRAF, other genes in a pathway called the MAP kinase pathway. And so that knowledge has opened up the opportunity to start to think about them as different diseases and to treat them in a different way. We've known for years that the sort of standard carboplatin Taxol chemotherapy that can cause high-grade serous cancer to just melt away really has very little activity in low-grade serous, but we always did it anyway because it wasn't like we had anything else we could do. So we did what we knew how to do. But more recently, we've come to appreciate better that these low-grade cancers are more susceptible to hormonal therapy. They have the estrogen and progesterone receptors, and a drug like letrozole that blocks the production of estrogen in the body can have a positive effect in treating low-grade serous and delaying a recurrence or causing shrinkage if you have active disease. And then more recently, other sort of biological targeted drugs like trametinib, which targets the MAP kinase pathway, was FDA approved a couple of years ago and has become widely used as a therapy for recurrent disease. And there's a number of other drugs in that pathway that are under development or close to approval. And so I think that the low-grade serous cancers tend to be slower growing, and patients tend to live longer on average in general, like maybe 7 or 8 years. But most of them do present a stage 3 disease and tend to persist and recur over years. So as we're developing more therapies based on our understanding of the biology, it's really been beneficial and patients are living longer.
Yeah. I think my cheer for all ovarian cancers is always 10 is not enough. Even 10-year survival is not enough. We really do want to go for a cure or letting you to be able to grow really old to die from something else, but not from ovarian cancer.
But I'd also say our low-grade patients tend to be younger. So I think also
Yes.
that sort of fertility
Yeah.
piece becomes a bigger part too for a lot of these patients. But I also think it's super exciting that we are having all these options, because maybe we will get rid of chemotherapy with the trial looking at giving Taxol carboplatin, as you said, and then versus just letrozole alone, because a lot of us don't feel that chemotherapy is as effective. So we're doing the trials to maybe de-escalate chemotherapy as an option and upfront. So I think it's nice to see that we're able to do trials, because we always used to think these are rare tumors. Can we really do a trial? And now we've done lots of phase 2s and even some now phase 3 trials. So we are moving the bar for our low-grade patients as well. So I think that's kudos to the community and all the people who fundraise to get us grant dollars, because I know we've been told in the past that, you know, these rare tumors are not as much of an interest, but you can now see we're making breakthroughs even for our low-grade patients.
Yeah, and I would just say, you know, again, I mentioned earlier, science, society of, you know, making sure everyone can have access, democratize access to some of the genetic testing we were talking about. But I think the FDA has really become a partner with us in the approvals and in the trial designs they're accepting for some of these rarer tumors where we don't really need randomized trials, and have been able to see these advances. So I think, as you're saying, you know, learning from other tumors for organ agnostic approaches, looking at hormonal pathways using aromatase inhibitors, whether or not to use some of the cyclin inhibitors as well with the aromatase inhibitors that we've seen so effective in breast cancer, being used with low-grade serous ovary cancer, and as Dr. Berchuck was mentioning, with the MEK, you know, pathway, RAF MEK pathways, and also some new trials that have been recently reported, like, you know, the RAMP 201 trial that we just.
Yeah, so that's actually a really exciting trial that was looking at using, you know, not only the MAP kinase pathway, but actually looking at adding a FAC inhibitor. And these are also oral agents, so they're not intravenous as well. And so it did show a very dramatic benefit. There was a huge amount of partial responses and complete responses that was just presented at the European Society of Medical Oncology, which was just last week. And so
hot off the press.
Yeah, hot off the press, and definitely also had stabilization. So these patients, interestingly enough, could have also had a MEK inhibitor prior, and still showed a response. So showing that this dual agent is really beneficial, and it's going to advance into a phase 3 trial where it's going to be looking at this combination versus chemotherapy, and it'll be an international trial as well. So it also shows that a global community are making these advances. It's not just being done in one country. So I think that's another great part of science. It really brings together the best minds to sort of advance the science as well.
I think team science really is the only paradigm today. And with a disease like ovarian cancer and low-grade serous cancer, we need these large international trials to have a meaningful readout and results for our patients. Let's switch gears to clear cell cancer, another less common ovarian cancer subtype, but one that we're seeing more and more being associated with endometriosis, also not as responsive to platinum chemotherapies. Do you want to comment, Andy, on some of the new approaches to clear cell tumors?
Yeah, I can say a few things, I guess. You know, again, with the ability to do next-gen sequencing type assays, we've learned that we think all clear cell cancers start from endometriosis, which is basically endometrial tissue that's growing in the abdomen, on the ovary or elsewhere. But when you look at the molecular profiles of these tumors, there's, I think, about 15 or 20% that are p53 mutated, you know, similar to high-grade serous, and tend to be more aggressive and have a worse outcome. And the majority don't have the p53 mutation. So we're definitely able to discern some sort of subsets there. I think increasingly there's some less than perfect data, but data nonetheless suggesting that in some cases radiation maybe that clear cell cancers of the ovary are more susceptible to a benefit from radiation than other types of epithelial ovarian cancer. So that's something to consider.
They may be more sensitive to immunotherapy. There've been trials looking at immunotherapy.
Yeah, so certainly the cancers that arise from endometriosis, the endometrioid and clear cell, are more likely to have microsatellite instability and could be candidates for immune checkpoint therapy. Although I must say, in my own practice, I can't off the top of my head think of a patient like that I've identified. I don't know, Premal, have you?
No, but I think there's the PEACOCK
CRs.
study. So there's a PEACOCK study that was actually done, I think, by Dr. Banerjee maybe last year at ESMO, which looked at the clear cell data and using pembrolizumab, and it did show encouraging benefit as well. So it was like a tumor directed, and I believe I haven't seen the basic science, but I believe there was a basic science component to try to understand response.
There was an NRG study looking at ipilimumab and Nivo, Ipi and Nivo together.
Right.
And that also showed benefit. I mean, the group in that cohort that had the most benefit were all the clear cell patients. And I've had, 2 patients who were platinum refractory growing right through their initial platinum that have had CRs.
And was that based on expression, on microsatellite instability, or just based on the histology and treating?
Histology alone.
Interesting.
Truly refractory progression on their induction chemo, have had CRs and are now 3 years out. So I think we look at them. I think the MMR, ARID1A, as you know, there's a number, the PIK3 kinase, there are agents targeting those as well. I think the point is clear cell tumors we recognize are distinct. We recognize they are more platinum resistant. Using modalities, whether it's radiation, immunotherapy, other targeted treatments. I would say that, while they may be more common in those of Asian ancestry, some of the early studies out of Japan using irinotecan and other types of agents have not shown, in terms of the upfront chemotherapy, that that's any better than our carboplatin and Taxol. But I do think it's an area that we're very interested in, more research in endometriosis and how that might be a precursor lesion, as you're saying.
Well, and should we consider it a pre-cancer? It's kind of hard because I think like 8 to 10% of women have self-reported endometriosis, and actual numbers may be higher. So clearly, very few of those women ever develop endometrioid or clear cell cancer. But, endometriosis is a hormonally responsive tissue. So certainly folks have considered hormonal approaches like progestins or other sorts of agents to try to suppress endometriosis and reduce risk of these cancers. But it's kind of a problem, needle in a haystack kind of thing. Like, how many would you have to treat to sort of prevent one death from those cancers? There
has been some interesting studies using single cell analysis, looking at, again, microenvironment. Is it an endometrioma on the ovary versus an implant in the cul-de-sac, and saying perhaps it's some of the implants off of the ovary that with a different microenvironment, different inflammatory environment might be more at risk, but I think that still needs to be confirmed with a lot more data. Premal, any other approaches you've had experience with for your patients with clear cell?
No, I think you mentioned, quite a few. And I think for the ARID1A, what I've done is, because you do see it commonly, is try to look at our medical oncology colleagues, because sometimes they have basket trials or, phase 1 or early trials, because I think we mentioned on our earlier segment how clinical trials really give you lots of opportunities. And now we have lots of agnostic trials, meaning they're really driven by what we talked about, the somatic mutations of a tumor. So that really can open opportunities that we did not think of. And so really talking to your physician or, whoever your provider is about those options, because there's always something out there, I guess, is what we're trying to all say in some way.
Yeah, I mean, it seems like many of these comments are based on the molecular analysis. And I think we kind of take it for granted now that we can get next-gen
Somatic
sequencing tests. There's a number of commercial providers. Our institution is starting now to do its own in-house sort of test that's even more readily available. And so, it's gratifying. Beth and I started off when we were just sort of getting into this era of finding out the genes that cause these cancers. And now you've got these, comprehensive tests that can look at pretty much every gene that's known to, have a mutation in any type of cancer and come back to the patient with a report. And it really lays the groundwork for the advances that have happened and those that are coming ahead in the future.
Yeah, no, I think we've seen enormous improvements in patient outcomes, treatment opportunities, based on the investment in the science and our, not stopping for what we have today. We have to do better for tomorrow, and really partnering with patients to allow us to make that happen. Can we talk about mucinous tumors for a moment? Another tumor that's a rare subtype. Also not as platinum sensitive. Another bugaboo for all of us when we see patients with mucinous tumors. Premal, do you want to start on that one for us for a moment?
Sure. So I think I love these bugaboos. We're having quite a few of them. But I will say mucinous is definitely challenging because it does not seem to be as chemo responsive. I think the one thing also to always ensure is that it truly is an ovarian cancer, and our pathologist can help us with that, because sometimes we do see metastasis from a colon cancer or another gastrointestinal cancer that comes to the ovary, which might be the larger metastatic portion, but it's not really the primary. So, getting your colonoscopy, endoscopies done. But on that aspect, I think, it's been hard to do trials in this arena because of the rarity of it. But we have really tried to use more of like a sort of a GI cocktail with oxaliplatin and 5-FU and trying to do more of that as opposed to using Taxol carbo platin. But, we also then look to see, is there a molecular profile? Like, is there a Lynch sort of like characteristic or something that would make them, amenable to another type of treatment? But
well, and some of these have overexpression of HER2.
Right.
I've had a few
HER2 and BRAF,
that we've treated with Herceptin, and now with other HER2 targeted agents. I think there's some options out there.
Yeah, with the antibody drug conjugates that we were talking about in our last session, they're getting better, right? Before we always used to just think of only Herceptin or trastuzumab, which has been around, but there's a lot of newer agents. So you don't necessarily even need as high of an expression as we had looked at before, right? So, that we might be able to target these, cancers much more effectively.
HER2, BRAF, looking at the tumors. But I think in each of these rare tumors, the somatic testing becomes even more important. We still, you still can have a germline predisposition as well, but the somatic testing really can be essential to getting you the best treatment possible, especially in these rarer tumors where our standard carboplatin and paclitaxel are not as effective. So again, it is going to be covered by insurers, and discuss it with your physician if you've not yet had it done, because as we've been talking about the clinical trials, these idea of basket trials, when we say organ agnostic, it's, anyone who has that gene mutation is eligible for the trial, whether or not it's from a breast, a colon, an ovary, or a prostate. So thinking about that, knowing about your own tumor. We have a few minutes left. There were also a couple of questions about borderline tumors, just while we're going through the gambit of epithelial ovarian cancers. And you want to say a few words on tumors of low malignant potential?
Well, I say they're called borderline tumors because they're on the borderline of cancer and not cancer. And fortunately, most of these act in a benign fashion, but occasionally they can sort of transform and become more full-fledged, life-threatening malignancies. We were just talking about mucinous cancer, and a group that both of us are involved with, Beth, and Premal, you may be as well. I can't remember. It's a big group, but the Ovarian Cancer Association Consortium has done a lot of work with the genetics, risk factors, and so forth of the various types of epithelial ovarian cancer. And, you alluded to before about concerned that some mucinous cancers may be actually metastatic to the ovary. That was always the dogma when we were in training, was like, most of these are metastatic. It's very rare to have a mucinous primary ovarian cancer, because what's the precursor cell? There's no mucinous epithelium in the tube or ovary. So how could there be primary mucinous ovarian cancer? But in fact, no one would say that a mucinous borderline tumor is metastatic to the ovary. I mean, that's got to be primary. And so we found that some of the common low penetrance variants that predispose to mucinous ovarian cancers, those same variants also predispose to mucinous borderline tumors. So I think it provides some pretty compelling evidence that these are actually, primary ovarian tumors. And so, generally, whether it's mucinous or serous, we think of a progression where, borderline is sort of on the borderline, and invasive cancer, is the full-blown malignancy. And a borderline mucinous and an invasive mucinous, and a borderline serous and invasive serous, I think, tend to share a lot of the same sorts of genetic changes. And so, I believe that they are related in that way. But again, fortunately, the borderline tumors are rarely life-threatening. So
transformation to malignancy is uncommon. I think chemotherapy is not used in borderline tumors. It is something I think Dr. Thaker was saying earlier about using the scalpel. I mean, but usually they are sizable masses that require surgery. Often, since they happen in younger women, if it's a cyst, and sometimes you can sometimes just do a cystectomy and leave the rest of the ovary, you may be at a higher risk of having a recurrent borderline. But because they have such an indolent biology, it may allow you to preserve fertility longer if that's something that's important to you. But I think they do require surgery. They rarely, I can't think of a single borderline tumor I would give systemic chemotherapy to. But you can have, at some point, rarely they can transform and become have more malignant behavior. But that is really a rare occurrence. I think we spoke a little bit about early stage cancers. The idea that although many of them may still need chemotherapy, they can often be cured. Still should have genetic testing. Still should have additional screening if indeed you're found to carry one of those genes. But our time is winding down. Why don't I give each of us an opportunity, just closing thoughts for those that are attending here today. Dr. Berchuck, you want to begin?
Yes, so we skipped over genetic testing a little faster than I'd hoped we would. As I said, it sounds like both of us have gotten more involved in our hereditary cancer clinics of late. And it really bothers me how 30 years after the discovery of BRCA1 and 2, we're still doing such a poor job with cascade testing, where, we test an ovarian cancer patient, they have a mutation, and then we know siblings, children, nieces, nephews, are all potentially at risk. And somehow, I saw a study recently that said only like 45% of the time is the cascade testing successful. So, to me, this is the great opportunity that we're just leaving on the table still. And, as I've gotten involved in our program here and worked with our genetic counselors, I've learned about approaches to this. One thing I was unaware of, because I guess I'm too busy treating cancer until this past year, is that the genetic counselors can give a patient a letter for their family. Because, they always say, tell your cousin that you have BRCA1 and they should get tested. Well, there's a number of obstacles there, from whether they even speak to their cousin or not, but the genetic counselor can give the patient a letter that they can then send to all the family members saying, I have this, this is the risk to you. And, there's a number of other approaches that are being developed, from chatbots to artificial intelligence to you name it. But we've got a lot of work to do there. And like I said, it's an opportunity that we just haven't really taken advantage of fully.
So when we talk about precision prevention, that's just it, is getting the cascading done. In general, we do a poor job. We routinely have been giving out letters. We now have been automating things with patient navigators to help individuals share that important information. But family dynamics are family dynamics. Genetic testing in general, and cascade in particular, again, when you get out to second and third degree relatives, gets to be much less. In underrepresented populations, it's even less. Again, they're not getting the testing often. There's perhaps implicit bias. So I think finding ways to democratize this information, and I think the precision prevention, the cascade testing is a really, really important opportunity for us to think more about.
So I'd
Dr. Thaker?
implore the people of this meeting to really take this to heart and think about it, because you're the ones who can make a difference, because you've all
As I said,
probably been
Thanksgiving.
tested.
Yeah.
Thanksgiving, you know?
Yes.
Well, I think it's my final thoughts are, it's great that you're here getting the education, do the advocacy that you help us so much, because hopefully you're seeing the benefits of the science that you are supporting with being the generous, patient who's willing to enroll in a trial, give biobank specimens, because we will continue to make progress only all together. So thank you for listening. And, I hope you continue to fight the fight with us.
Right. And I think, as they say, uniting for hope. That's the title of this year's session, this year's conference. And I think you've heard from all of us who've been really focusing our life's work on caring for women with ovarian cancer for many decades. This is an exciting time. Berchuck and I were together long before we knew about BRCA, and we're just collecting family pedigrees. We've now seen that come from gene discovery, testing, PARP inhibitors, new targeted therapies, all the work you've heard about, I hope, from us this morning. Take notes. There are many other sessions, as I said, some on demand, about rare cancers, experimental therapies, managing recurrence, what's happening with the PARP inhibitors, the drug shortage. Take advantage of the conference. This is an exciting time. Bring together community. And as we said, keep advocating, keep learning, and give us feedback whenever you'd like. So thank you very much, and have a good day. Enjoy the rest of the conference.